Today I'm going to talk about, as I mentioned, AI in the global context. And as I prepared for this, I started realizing that, many of the challenges that are in low-income countries, some of them are also equally applicable to developed countries. And so it's just that in developing countries, the problems are more extreme. But as we try to do more of this kind of work at scale, I think a lot of the questions have synergy, and I think both sides have a lot to learn. And in my years that I've been working in global health, I've really enjoyed the collaboration with those countries. Sometimes because of necessity, they come up with very, very creative solutions. So I encourage people as you develop your careers to explore global health. I think it'll be a really rewarding experience. So why is this topic really important? Well, one of the big challenges we'll have both here in Canada, US, and around the world is really a shortage of healthcare providers. We have a growing population, people are living longer and with more chronic conditions, yet the number of physicians and allied healthcare workers really isn't keeping pace with the demand. So we are going to have to find ways to treat more patients and in better ways with fewer people. And so using technology in innovative ways will become really important. It's particularly important in developing countries or in countries with limited resources. And here you'll see that the number of doctors, nurses, and midwives per 1,000 people becomes really challenging in the South Pacific and the Middle East, but extremely challenging in Africa and sub-Saharan Africa. And so the question is, what AI technology can we bring to different regions? What does it make sense, given that they already have limited resources, but they also have a great amount of need? So some of the things that have been applied in globally that has been particularly useful are things such as tuberculosis, which has a higher occurrence in these countries. And so AI makes sense to be able to deploy in that area. Dengue fever has hit particularly hard in many of these countries, and the Zika virus, and so machine learning algorithms have been used to identify transmission and how to be able to detect the spread of those diseases. And people have also used it, for example, to look at different ways of deploying healthcare workers to underserved community and what's the optimal way of being able to deploy those. So all of those things are particularly useful. And so when it comes to developing strategies, this paper here in 2020 provided a framework for how to develop a strategy for AI in low and middle income countries. And it looks at being able to look at how to do appropriate research given the data challenges that there are, and how to create algorithms that can deal with limited amounts of data, how to assess methods and build consensus. Which project should you work on, I think, is important, given that you won't be able to do all of them, and you have to be very carefully selective in which ones you implement, and then how you go about implementing them and evaluating them using that. All of this, I think, speaks to a real need to provide more training. And so the fact that you're making, for example, this course available online, I think is a really outstanding contribution. The USAID is an agency of the United States government, partnered with the Rockefeller Foundation to look at AI in global health, and issued this report in 2019, looking at strategies for how to develop AI in these countries. And they keyed on a couple of areas, and I'll just highlight on some of these. For example, data quality and availability is a real challenge. So given that you have limited resources, you have to figure out innovative ways to collect that data and make sure that it's of good enough quality to be able to reason with it. being able to look at how to do evaluation of that and the evidence of impact becomes important. So what's more meaningful in these countries might be different. So we have to look at different evaluation methods. And as I mentioned earlier, there are some building blocks that are needed, and one of them is training, and particularly in languages that are local to those countries. And this other chart sort of breaks it down even more in terms of providing opportunities for innovators at different levels, and creating interoperability, particularly using technologies such as mobile apps and phones that could be used to collect data and transmit them more easily. And finally, capacity building, which is, I think, a real challenge globally, but particularly in low and middle income countries. So I'm going to look at a few topics from what we've just seen there and highlight some of the challenges and innovative approaches that have been used to solve this. And so in a resource-rich area, you might be able to look at data that you get through medical records and testing registries and telemedicine consults. The problem is that in a lot of these countries, very few centers have electronic medical records, and they're not necessarily connected. And things that we do more here in higher income countries, such as remote health monitoring and Bluetooth, may not be as available and deployed. But in the last 10 or so years, a lot of innovation has come in these countries using phones as data and internet cell phone plans have become more available. And I think some of those lessons of innovation could be brought back here. And so there are a lot of startups and nonprofits doing some really innovative mobile apps in that space. And so the question is, how can we improve the data collection? How do we properly consent? And this is a global problem, but it's particularly important in countries where perhaps education levels are lower, or health literacy is lower, or something known as technology literacy, where people don't quite understand the concept of a cloud or how that data might actually get used beyond their borders. Again, these problems are also here in our countries, but we talk about them more, and it's and so I think we need to be able to do ethically the right way to sort of communicate how that data is being collected and how it's being used. Encoding that data in a way that can be used is really important. And we have to start developing better standards and training for how to code that data. And I think the pandemic has certainly shown that healthcare really is global. So something that starts in one part of the world can easily spread. And unless we make data sharing a priority and start developing the infrastructure for sharing data globally, we're going to have a lot of trouble dealing with pandemics and other global challenges. So the challenge in any healthcare system is that there's just a lot of data. And so this chart from the World Health Organization shows different types of data sources that are available in our environments. And I think the need to try to develop innovative solutions is to be very selective as to which data points might be the most useful to collect to be able to develop innovative solutions. One of the things that's been talked about in this course and in many AI circles is, how do you know if the solutions are actually valid, and how do you evaluate them? And so part of that is documenting what data you've collected and how you've analyzed it, what were the sources, and how it was transformed into that data. And all of that speaks to clear documentation standards so that people who are trying to evaluate it can do that. And so in some of the work that I've been doing is we've developed we've obtained a grant for the next 5 years to train cancer researchers in sub-Saharan Africa on how to do precision medicine and how to collect data. And it has 2 tracks, one for the researchers who are going to develop the studies, and another one is for the project managers and data managers to teach them best practices for how to document the management of those clinical studies. And this is all part of an initiative to sort of create capacity so that they can not only implement some of these advanced tailored therapies, but also become scientists and be able to analyze their own data and be able to manage their own data. And so there was this interesting chart that shows the process of how you can go about transforming data. And I think most of you have probably seen different models for how the data can be transformed. But really, to be able to get to the point where you can do reasoning, you really have to take careful note of how that data was transformed and labeled and optimized. So as you're evaluating it, you can see the limitations of the data. And sometimes we don't do this enough. And in particular, more recently, people are starting to see some of the problems of bias. And part of that is hard to assess if you haven't documented the sources of data and the classification of that data. As we aggregate data across institutions and across borders, I think it's important to be able to preserve the privacy of people. And there are different levels in which you can de-identify the data. And so this chart shows you different approaches and levels of how to de-identify that. And as you develop these large-scale studies, there has to be a discussion on what privacy is needed. At some point, if you anonymize the data completely, you might not be able to do the kind of research that you do, especially if you need to link that data to clinical records. But there is a whole range. It's not a binary choice, and people need to have this discussion and be trained on the methods and the tools. In developing countries, as I mentioned, they've done a lot of innovative solutions, and one of the things that I admire the most is their ability to sort of collaborate through open source initiatives. This example is from Ethiopia, where they developed an open source system to aggregate data from different centers so that they can identify hotspots, and they use GitHub to sort of share that repository. So there are various medical records that are open source. OpenMRS is one example that's been widely deployed. And I really admire their collaborative spirit and innovation in that area. But as you aggregate that data, you also, as I mentioned, need to be careful about how you classify that data so you can make sure you're comparing similar types of data. So as you know, there are different taxonomies and terminologies that people use around the world for classifying their data. One of the initiatives that has come up from these international consortiums, led by people like Dr. Andy Cantor, who's with IMO, and several other groups, including groups in Africa, is the Open Concept Lab. And this is a way of sharing terminology and having a server that has that data in an open access way and be able to map those different terms. And they've linked this to the OpenMRS medical record, but it can be linked to any other system. So this is sort of a way in which we can start to sort of publicly share that those terminologies and train people to do it. And so more of this work is going to have to happen for us to be able to aggregate data and be able to do large-scale AI. As you know, COVID required us to be able to aggregate a lot of data quickly to be able to come up to the vaccine. Some nonprofits stepped up to the plate to make that data more accessible. Some governments also did some of that work. This is just one example of many where this was aggregated. So the Allen Institute created this COVID-19 database that had scholarly articles, and some of these other organizations have also aggregated data sets that you can analyze. And I think this type of work needs to continue beyond the pandemic so that we can be able to do research at scale and be able to solve some of the problems, not just pandemics. The problem is sometimes we have multiple initiatives, and they don't always necessarily converge. And so I'll give you a few examples here in the United States that are very large, haven't yet converged, but one of them is the 4CE initiative. This is a consortium based using a platform called I2B2, which is a database that can be used to aggregate biomedical database, developed here at Harvard, but used globally. It's an open source software. And they've used I2B2 to sort of collect and aggregate data for COVID-19. And there's a citation to a recent description of that network. There's another one that started, I believe, in Johns Hopkins, the NC3 consortium, which has 34 hospitals in the United States aggregating data. And then there's this Phoenix toolkit, which has different ways, initially started for genomic databases in terms of terminology, standards for comparing it. They've expanded it into also ways of standardizing social determinants of health, which are really useful for, particularly for global health, but even in any of our countries to be able to understand outcomes. And they say that anywhere between 20 and 60% of outcomes are dependent on social determinants of health. And we don't actually collect those consistently enough or accurately enough to be able to do large scale studies. So in the United States, there's currently an initiative. It's about a $1.5 billion initiative to help coordinate more of these long-term studies for COVID. And the hope is to be able to create some standards and aggregation of that data. So that project is underway. They've asked several groups to sort of bid. We're one of them. There's a Boston consortium that has submitted. And the hope is that as this gets funded and rolled out, we'll have more standardization. But we need to do this also at the global level. And it speaks to the need to sort of provide resources for other parts around the world to be able to create these databases, or at least be able to use what has already been developed in other places so that we can have more global repositories. One area where people have been doing a lot of data sharing is on the pathogen genome data as it relates to the COVID virus. And here you see this website called NextStrain, which has been tracking and documenting the different variants. And you'll see here, last year in December, there was 1878 different types of variants. There are clusters of variants, so there are variations of this, but you can also see the tracking. And so this has helped a lot of scientific groups to be able to analyze the development. This is a recent snapshot, and so we're up to almost 4,000 different variants. And here you see on the left some of those variants, including the Delta variant, which is sort of sweeping large parts of the world. So again, global health can only be tackled through global collaborations. So one of the interesting problems that we had in the last year that required urgent attention is to really understand how COVID-19 was spreading. And because we didn't really have great infrastructure worldwide to be able to access all the medical data, and not everyone has electronic medical records, we needed to find innovative ways to be able to track those diseases. And so the challenge to be able to apply AI for this problem is really to be able to access innovative sources of data, and then be able to transform those algorithms to that data, and to be able to make accurate predictions, and be able to understand how those algorithms, how valid and reliable they were. So a tremendous amount of innovation has happened in there. But one of the things that we need to continue to do is to sort of be able to transparently evaluate these algorithms to know where are their weaknesses, how brittle are they in terms of when there's incomplete data or unreliable data, and how reliable are those predictions. So I'm just going to show you a few initiatives that have been done that I think have been quite innovative. This one was an early prediction model coming out of China, where they looked at information about where people were traveling based on trains, train information. And using that information, they were able, and models of how diseases normally spread, they were able to combine both traditional prediction models with some AI prediction models to get a fairly accurate prediction of how the disease was going to spread through China. And this is just an example of the information that model that they used. This is the traditional model, and then the AI component is they use this long short-term memory model to be able to take in the data from the train information and then use that train transport information and the early information about how the disease was spreading to be able to train this neural network and create a more accurate prediction model. Another innovative strategy was to look at tweets and that people were doing. And so some of these data sets have become available, and you can sort of see some of these data sets. There's a website called Kaggle that has some of these data sets available for you. The surprising thing, there's 608 data sets, so there's lots of data available. Another innovative approach came from Dr. John Brownstein's group here at Harvard, and he's at Boston Children's, Chief Innovation Officer, and he's been working for many years on a platform called HealthMap that looks at data from different sources, including social media, news reports, to be able to look at the transmission of different diseases. And they were quickly able to apply that to COVID-19 and be able to develop predictive models. So when you don't have medical record data, you can look at other sources of data to do it. This one's from Canada, a company called Blue Dot, who used air travel patterns, unusual air travel patterns. So they tapped into the number of flights that were happening and then connected it to news reports. And they claimed to be one of the first companies to be able to predict the outbreak on that. I think one of the things we need to, in all of these systems, is to really have access to the data so that we can actually be able to validate them. But I understand that these are also private sector companies, and there are many now of these companies doing this type of work. Here's another one called Biota that has developed technologies for the spread of diseases, and they sell that information, predictive models, to the insurance companies and other large companies that want to understand how this is going to affect the economy. And so prediction in this has now become big business. And as we do that, the accessibility of that data, I think, is going to be important, so that not only these big companies can be able to do that research, but that also that academics can do that research, and there's public accessibility. So one of the other things that was done before SARS is the CDC was trying to deal with the Ebola outbreak. And because there are very few electronic medical records in that part of Africa where it broke out, and even cell phone connectivity sometimes wasn't particularly good, they resorted to using aerial photographs to look at cities. And as the Ebola pandemic spread, they noticed that certain roads were no longer being used. And so on the left, you see when the city was, people were living there and traveling, and so the roads were clearly marked, and there's bushes and gardens. And on the right, this particular village was had a lot of people who had died from Ebola, and the village has become largely abandoned. And so they were able to use aerial photographs to sort of see where it was spreading and be able to send response teams to different parts of it. There are other groups have also used, for example, mobile phone traffic. So the earlier one used train travel as this. This one used where people were using their phones and how people were moving. And so this study was also from China and was able to track the spread of the disease based on where people were traveling to. And another aerial sort of analysis, this is also from John Brownstein and his team. And by the way, John Brownstein is Canadian. He was trained in McGill. And so here you see photographs of different hospitals in China. They counted the number of cars that were in there and compared it month to month, and were able to see significant differences in the volume of patients. And so this particular paper, which some people dispute, but I believe their methods are fairly rigorous and public, so you can judge yourself. But this one shows that there was activity in the fall, a larger number of activity at some of these hospitals in the fall. So that could be another way in which you can detect unusual health patterns. And this is just another visual representation of how they saw the volume of cars at the different areas. And you see that in November 2019, there was already a spike. One of the things that we've been looking at also is how to predict the spread of it based on how people react to public health measures. And so this is another Boston area tool that you can go to. And it looks at the simulation of the spread. But the interesting thing about this tool is that you can go and look at what restrictions you might put, for example, lockdown, have masks, and you can say for how long you'll do those restrictions. And so in this case, I put in our current situation here in the United States, and I switched them all to minimal restrictions, which means no masks and no lockdowns. The disturbing thing is here, you'll see that the prediction is that by September and October, we're going to see another surge. And so this is based on how people have reacted to public health measures and what the incidence rate has been as a result. They've done, you can do this actually by state. And so a lot of fine-grained models have been developed based on historical data to be able, and they've become more accurate. Here you see what would happen if today in the United States we had 8 weeks of stay-at-home orders, and then after that go back to where we are now. You see, actually, this model would predict that we'd actually be pretty well done with this COVID by the end of August. But it's unlikely that most states want to go back to restrictions because people are fed up. But these types of models are increasingly available, and we need to find innovative ways to be able to get good data, but at the same time, be able to evaluate the limitations of this and make sure that we don't overreact and create public responses. So the need to validate this data, especially if we're basing it on public policy, becomes really, really important. Other examples of global health activity, other people have used satellite imagery to look at the delays of ships leaving their ports. And so there are certain things that you need for medical supplies, such as PPEs. Those PPEs, for example, have certain components. Even the vaccines need certain types of components which only come from certain parts of the world. And so the flow of traffic or the delays in those will cause delays in the manufacture of everything from computer chips to medications to PPE, which in turn can affect how we're able to respond to the responses. So for example, here, this particular chart shows the delays of that particular port. And the interesting thing is that 90% of the world's electronic components, essential components, come out of this port. So a delay in that port affects all of the world. And we've seen that in that, for example, cars have had trouble getting chips and many other devices that they need to do that. When it comes to PPE, I don't know if you remember that there was at one point a couple of days when the US wanted to stop sending masks to Canada, and so they wanted to prevent 3M to send masks. And the Canadians quickly pointed out that those 3M masks and many other masks depend on a certain fiber, and that fiber happens, one of the places where you find that fiber is in British Columbia, in Vancouver Island. And so there's a picture of one of my favorite trees, that Chihuahua cedar in Pacific Rim Park. And so the global supply chain for these essential components is really important to make sure that we have enough components for people to be able to do that. At the same time, we have to be really careful that we don't destroy our environment. And one of the sad things is that in Vancouver Island, and like in many other places of the world, we've cut down an awful lot of our forests. There's only 3% of your old growth forests left. And so we need a sustainable plan for global that's responsible. And that discussion requires diplomacy, and AI could be used to predict what some of those problems are. So speaking of predictions of essential supplies and pandemics, the US government had a simulation called Crimson Contagion. And they did this in the first part of 2019, where they simulated a situation where a pandemic occurred based on a traveler bringing back a novel type of influenza. They did this simulation with 12 federal agencies and tons of departments and hospitals. And in this simulation, after 6 months, they discovered that it would spread rapidly and that they would not have enough on-hand essential supplies for respirators and masks. And of course, lo and behold, we had COVID and a lot of this. The problem, I think, with some of these things is not that we've done the simulations, is that we haven't done anything after the simulations to actually take a proactive response. And then the Gates Foundation and the World Economic Forum and Johns Hopkins have done 2 pandemic simulations. The last one was called Event 201. It was held October 18th, 2019, where they simulated with computer models and expert representatives from governments and businesses, what would a pandemic look like. And in this scenario, played over 3 hours, which simulated 18 months of real time, 65 million people were dead, and similar things about shortage of essential supplies. So we really need to not only continue to develop predictive models, but more importantly, we need to actually use that knowledge for public good. So I want to sort of start to wrap up in terms of how do we use this AI for global health and public good. And so there are certainly implications that can be done in terms of proactive things to prevent future based on what we've learned from these models. But there could also be other things that may have deep consequential effects. For example, if the model is wrong and we're using that for example, border closings, then we may actually create economic harm. And so we actually need these models to be accurate and validation to do this. So this paper was published before the pandemic, simulated what would happen if somebody arrived at an airport and you started closing airports to reduce the spread of it. And they used different scenarios for different mitigation processes to be able to do that. So I think this is useful work. We just have to make sure that these models are accurate and then we use them appropriately. And the thing is that this is not just a health issue, it has political and business consequences, but we need to have that open dialogue. So what are some policy implications about AI in healthcare? They can certainly influence, these algorithms can certainly influence public policy, but to be able to do this properly and do it equitably, we really need to have good data, and we need to help different regions of the world be able to collect that data so that they can do their own analysis and have informed decisions. And part of the question is, what's the role of citizens and what are the ethical standards for using that? So there are a bunch of different organizations that have thought about this quite a bit. One of them is the Inter-American Bank, which funds a lot of work and development in Latin America. This is different than the World Bank, but similar in nature, providing economic development. And they started looking at how AI could be useful in the pandemic in socially responsible ways. The National Academies of Medicine, which is like a think tank in the United States, came up with a document in 2019 looking at AI in healthcare and looking at different principles of how it could be developed responsibly. And there were a lot of good ideas that came out of that. More recently, very recently actually, on the 20th of June, the World Health Organization issued ethical guidelines for the use of AI in health. And there's some really good principles in there. And one of them that has been talked about in this course has been sort of protecting human autonomy in there. And it looks at issues such as making sure that this technology is being used for the well-being and safety of the public interest, making sure that there's transparency, explainability, and intelligibility of these algorithms, making sure that it's being used responsibly and there's accountability, and that there's also inclusiveness and equity in this. I'm going to talk about equity in just a moment, and make sure that it's responsible and sustainable. And to do it sustainable, we'll need to be able to think about the funding of this. So what do we mean by health equity, and what's the role of AI in that? Well, different groups have thought about this for a long time. One of them is the Robert Wood Johnson Foundation, a nonprofit in the United States, and they collected different sets of scholars and stakeholders to think about this and came up with a document and a report that defined health equity as the means that everyone has a fair and just opportunity to be as healthy as possible. And they came up with principles of how this should be developed and approached. And in terms of AI, one of the big problems that we have is right now is that a lot of data sets don't have diversity, both in terms of ethnicity, race, gender, and other social determinants of health. And so if you're always doing research with conveniently accessible data from high-income countries, which predominantly have only one type of race and higher income type, then we're going to get algorithms that are tailored to those populations but may not benefit other groups. So I think we have to intentionally start collecting data that is diverse so that these benefits of these algorithms are equitably shared by the world. There's also bias in how these algorithms can be coded, and this has gotten a lot of attention. Of course, cognitive science has thought about this for a long time. This particular chart I thought was really impressive. It maps out 180 possible cognitive types of biases. And so as we evaluate them, we need to develop methodologies to make sure that we look at the bias in these algorithms and how those could be corrected. So I worked with colleagues from different locations and institutions, including IBM Watson, as well as some scholars from the United States and Australia. And we came up with this paper that was published recently, which is a framework for AI in health equity. And it's based on some of the earlier reports that I studied, looking at a formal way in which you can intentionally make sure that in every step of the process, health equity has been thought of. And so this particular diagram initially was from the National Academy of Medicine. And the parts that we've added is sort of the center part, which is looking at health equity and racial justice. And for each one of these steps, we talk about how to make sure that you incorporate equity into that design. And so this means that as you go about thinking about what projects you're going to work, what data you're going to collect, how that data will be aggregated, how it will be analyzed, is all important. Equity needs to be part of every single one of those. And you have to document how you've done those decisions so that then you can be able to assess the limitations of those studies based on how well or how not well you've done that equity. And that includes not only once you've developed it, but ongoing use of that technology to know when, for example, that technology is perhaps no longer applicable and needs further training data to be able to be effective. And so hopefully this type of proposal will get more adopted, and as people develop and document their solutions, they'll follow similar strategies to make sure that those solutions are equitable. So what are the take-home messages that I sort of have at this point from my observation of global health and AI? I think AI in global health has been used in really novel ways to predict, track the spread of diseases. But to be able to do this development or apply these algorithms, you need to have data. And many countries need help in being able to create the infrastructure, methods, and training to be able to collect that data. I think we need to, across the board in all countries, pay particular attention how we're validating these algorithms, especially if we take an algorithm from one part of the world with one type of population and try to use it elsewhere, be able to understand if that is actually valid or whether we need to do validations in those countries. And health equity, I think, is a really important part of that. I think data is the new gold currency. I think without data and having a transparent way of analyzing that data, we won't have equitable use. I think as we aggregate this data, we are going to need to make sure that we properly consent people and educate people on why we're collecting that data and where it's going to be used. And as we collect all of this data, a big part of this is also how we're going to govern the use of that data. And so data use and governance agreements, I think, are going to be important. And one of the things that has been mentioned in this class and in other circles is what happens when somebody misuses AI. And so we need to talk about what are the consequences and how do we hold people accountable for the misuse. So overall, I think there have been some innovative uses. We need more data and validation, and we need to take a global approach to make sure that the advances we do in innovation in medicine and AI are equitably shared with everyone around the world. And with that, I would like to thank you for coming to the seminar.